Hi friends, good evening. I'm Dr. Ashutosh Gupta, and today we are going to talk about PGT-A, right? So of late we are getting a lot of reports and counseling sessions regarding this PGT-A being sort of an multiple abnormalities that we are picking up on a PGT-A, right? So in the second part probably I'll explain all these things case to case, but let us first understand what happens in the background. What is the basic science to it? Okay. So whenever we are making the babies, so all the embryos will get into a fetal stage. The answer is no. So how much they would get into that fetal stage and we would have the baby is only one third. So meaning thereby that out of 100 we would have only 33% of the babies they will grow to that extent of something around 8 to 9 months. So this is the law of fecundity. Secondly, why does it happen? So it has to follow through a Darwin law, meaning thereby that it is the survival of the fittest. So most of the babies, something around 40-45%, they do have gross chromosomal abnormalities, meaning thereby even though we have made those embryos, they are not fit enough to really get into that fetal stage. So how they would land up? They would land up sort of in mitotic arrest, or they can have a belated ovum or a missed abortion. So this subcategory of something around 40-50% of the babies with chromosomal abnormality, they would be picked up by PGT-A. And second question is this: whether the baby can really rescue himself from out of this chromosomal abnormality. The answer is yes. So whenever we are doing this PGDA, it is being done from this trophoectoderm cells, and the inner cell mass, the cell mass which is there inside makes the baby. So the tropho-TE cells, they are more tolerant to do these aneuploidies, while on the other hand, the inner cell mass, if there is an aneuploidy in the inner cell mass, it will get into a mitotic arrest, meaning thereby that probably we will not get to that extent of having the 16 cell or a 32 cell stage, right? Third thing is this, that PGDA is a very sensitive tool so as to identify the abnormality or the chromosomal imbalances. But this is a true potential of the implantation to the baby apart from the abnormal genetic makeup to the fetus. Let me explain this in a greater detail. So there are only two things which is rate limiting. First is the implantation of those embryos, and second is the heartbeat. So these are the rate limiting factors. These are the great bottlenecks. So if the baby is able to survive through that area, and therefore the baby, this mosaicism would get downgraded as the baby would grow further up. So meaning thereby that whatever abnormality that we are picking up in PGDA, they are basically from trophoectoderm cells. They are usually mitotic, and those cell lines would die down on its own. So they are not in their inner cell mass. इसको दोबारा समझ लेते हैं. Ovum pickup, sperm, ICSI, embryos, and then we see the embryos under the microscope, and then we see them at 16 cell stage or a 32 cell stage, right? So baby, if there would be some aneuploidy to the inner cell mass, it would not get to 16 or 18 cell stage or a 32 cell stage. It would have a mitotic arrest earlier than that. तो बेबी अगर 32 पे या 16 सेल स्टेज पे आया है, तो इसका मतलब ये है कि द इनर सेल मास इज डूइंग गुड. So then the stage comes for a PGDA. So PGDA is not being done at 2 cell stage. It is done at 32 cell stage. So we take out some 2 to 5 cells. We do the aneuploidy. So PGDA is done by NGS. NGS doesn't looks around for the chromosomal imbalances. It is a read. It looks around for the DNA. It looks around for the DNA. It goes for the reads. It goes for the ratios. Right. So any embryo or any trophoblodom cells which has got a low DNA and would have false positive, lot of imbalances that would turn out to be trophoblodom cells. Now trophoectoderm cells are, they are mitotic, and they would just help in the implantation. So if the baby implants very well and then the conductivity is there, this aneuploidy or would get downgraded and we can have a normal baby, right? So nowadays the PGDA is telling us, and then they are making it milder, in which whatever embryos that we are testing, so we are talking about the implantation potential as compared to the genetic makeup of the baby, right? Let us go through these slides, and probably I'll try to explain all these things in a greater detail. तो एन्यूप्लॉइडी तकरीबन 40% होता है, इम्प्लांटेशन एबनॉर्मलिटी 20% के आसपास है, एंड वी कैन हैव सम मेटाबॉलिक एबनॉर्मलिटी टू द fetus also, right? So this is a Darwinian theory that they were not fit enough to really survive to make the embryos, right? So they would never get implanted, they would never get implanted. So PGDA would pick up all those babies which were, है ना, so meaning thereby that it helps us in emotional loss, in dealing with this time loss and then the money environment, right? These aneuploid babies, they can autocorrect, yes, they can autocorrect on their own, right? But PGDA picks up the typical aneuploidy, and therefore we would refrain from transferring those babies, right? And it is a very, very sensitive test, it is a very sensitive test to pick up those abnormalities. So cumulative success rate remains the same whether you do a PGDA or you don't do it, right? So trophoectoderm is very tolerant to those aneuploidies, but not the inner cell mass, right? So we will not get to the stage of an day 5 if the inner cell mass has got the aneuploidy, right? So the fetus will become normal, even though the trophoectoderm biopsy is telling us some abnormality is there, right? So PGDA is a NGS based. It looks around for the reads, right? And basically it might be false positive for the segmental loss and low level mosaicism and all those stuff. So this can be false positive, right? And once the baby attaches and the heartbeat is there is a usually a downgrade to this biological mosaicism, right? So the rate limiting step is only the implantation, second is the heartbeat. These are two great bottlenecks to which the baby has to pass through this thing. Once the baby has passed, so we identify that the genetic abnormality, the baby would autocorrect on its own, right? So this is very, very reassuring. It is a very sensitive test. Nowadays we are talking about the implantation potential of the babies apart from genetic abnormality to the fetus by PGDA. अगर PGDA की reports false positive आती है, so what is the big fun doing this PGDA test to all the embryos, right? The question is this, that probably 40-50% of the embryos being formed would be aneuploid, meaning thereby that we would have a large segment abnormality in the chromosomes. So not all the babies, naturally also in an IVF cycle also the success rate is only one third, right? So we are going to pick up, or we are going to test all those babies which are going to fail outrightly, right? So meaning thereby that it makes more sense that probably we do have a time saving, and then the emotional loss is there, and then probably recurrent we are having this fertilization failure. So definitely it helps to select those embryos which have got a good sort of an implantation potential as compared to the babies which outrightly would get into mitotic arrest. So meaning thereby that the PGDA has to be looked around by the microscopic clinical triaging of the fetuses or the embryos that we see under the microscope, right? So it is a stage 3. You do a home pickup, you do an ICSI, then you see the babies by 16 cell or 32 cell stage under microscope, and then we identify that it is a 4A or 4B as compared to 2A or 2B, and then you do a PGDA, right? So clinical triaging to the embryos under the microscope plus sort of an normal PGDA has got more implantation potential, and PGDA never ever tells us about the actual that the baby would be abnormal or the baby can have all these things. The baby would get autocorrected all these things. Okay. The thing is this, that probably we might need to do an amniocentesis 16 weeks or so. All these things are in trophoectoderm cells, not in the inner cell mass. If all these segmental aneuploidies would be there in the inner cell mass, you will not get to this stage by doing the PGDA. It would end up with a mitotic arrest at the 2 cell stage and 3 cell stage. The embryos will not grow, right? So many a times, and then it is an NGS technique. So that looks around for the reads, that looks around for the ratios. It doesn't look around for the chromosomes per se, right? And whenever we are having segmental abnormalities, many times we identify it to be false positive, right? Hopes this settles a lot of queries across. I'm going to post another in which we would do segmental loss specifically, then we'll talk about those segmental loss, what they do mean, and whether they are false positive. Okay, so watch out for that video also. Thank you very much for your patient listening.